From Luminary, this is Therapy versus the World. I'm your host, Joe Nucci, and together, with the help of our very special guests, we are going to arm ourselves with knowledge about mental health to tackle the more emotionally difficult topics of your life. We're going to talk about different buzzwords that you hear and know, like narcissism, self-esteem, trauma, and more. Hopefully, you will leave this show understanding yourself and others a little bit better. Today, I'm very, very excited to talk to Dr. Carlene MacMillan. Dr. Carlene MacMillan is the Chief Medical Officer at Osmind and is a practicing child and adolescent psychiatrist. Tell me, do you want to be referred to as Carlene or Dr. MacMillan? Does it matter?
People at work call me Dr. Carlene, so maybe we could go with
All
that.
right,
Yeah.
let's do it. Dr.
All right.
Carlene. So Dr. Carlene and I actually know each other a little bit. We connected years ago during the pandemic on
Mm-hmm.
Clubhouse, where Dr. Carlene hosted these amazing psychiatry AMAs, Ask Me Anything. I was actually wrapping up grad school at the time, and I found them incredibly informative, whether the topic was narcissism or transference or whatever it might be. And I'm very, very excited to talk to her today. And today, the topic we're diving into is, are shrinks crazier than their patients? Welcome, Dr. Carlene.
Thanks. Yeah, happy to be
Yeah.
here. It's weird seeing you here and not on Clubhouse back in the
Yes.
day. Yeah, yeah.
Totally. Well, before we dive into the topic in question, I'd love for you to talk a little bit about your background, where you went to school, what your experience has been like working in mental health, and what you're up to now.
Sure. So, yeah, I'm born and raised in Massachusetts. Went to college at Harvard, little school in Cambridge, and basically didn't look back. Stayed there for medical school, residency, as well as child psychiatry fellowship. And then after that, I worked at McLean Hospital, which is a very well-known psychiatric hospital in Massachusetts, before relocating to New York about 8 or so years ago. And now I basically do two things. I have a private practice in Brooklyn where we do innovative mental health treatments, rapid acting mental health treatments like TMS, transcranial magnetic stimulation, as well as actually work at a health tech company based out of California that does mental health EHRs basically. So
Yeah.
kind of two things.
And for those of us who don't know what those acronyms stand for, briefly, what is TMS and what is an EHR?
Yes, sorry. So TMS is transcranial magnetic stimulation. It's an FDA cleared treatment, been around for over a decade for the treatment of difficult to treat depression, and more recently for OCD. It's an in-office procedure where people come in and they basically use a magnet to cause neurons in the brain to fire. The saying we like to use is neurons that fire together wire together. So it basically wakes up that part of the brain that's underactive in depression, starts saying the neurons, "Hey, it's time to do something. It's time to grow. Time to open up to the world again." And it can be a remarkable treatment for difficult to treat depression that hasn't responded to many medications and psychotherapy. So really, I think groundbreaking, awesome treatment.
Yeah, we'll have to get into a little bit about that today. I first learned about TMS on Clubhouse,
Oh,
actually,
okay. From
when
us or someone else?
I believe it was either you, it may have been your partner who was
hmm
talking about it, but one of you or maybe both of you together. And really briefly, what is an EHR? What is Osmind?
Yeah, so electronic health record. Generally, these are the bane of existence of doctors, where we have to, document all of our findings when we see patients, track things over time, order medications. And as a physician, I got frustrated. I'd used over 10 of them in my career, and found they weren't really meeting the needs for what we do and the specialized work that we do. So Osmind really works with psychiatrists and other types of mental health practitioners to basically have purpose-built tools so that we can document and go through our day and deliver these types of treatments more easily.
Yeah, amazing. So let's get into it. When I reached out to you about this episode topic, you got back to me right away and you said that you are more than happy to talk about it and you seemed
hmm
quite eager. This question of, are shrinks crazier than their patients. I know it's a stereotype I've encountered when I decided to go to grad school and even working in the field as a mental health clinician. And I
Mhm.
guess I just wanted to know from you, what made the topic seem so important to you? Why does this matter?
hmm Yeah, I mean, I don't typically use the word crazy unless, we're all a little crazy is kind of my belief. We all have our quirks. But I think for me, there's a lot of othering that happens in medicine, in particular in mental health care, where it's the therapist or the psychiatrist is, in the position of authority, and then there's the patient. And oftentimes, the mental health clinician has their own lived experience with mental health and doesn't always want to talk about it. So I'm of the belief that talking about it helps reduce stigma, and helps instill hope. Not only just reduce stigma, which we talk a lot about, but really actually tell people, that there's treatments that work, that people can get better, and that it's really quite normal to have different types of mental health experiences over one's life that are challenging.
Yeah, the hope piece, I mean, both the hope and the stigma piece are really, really important. But for me, what comes up with the hope piece is I was recently talking to my team that edits my short form content. And I made a video recently where I disclosed that I do have ADHD. And they were all
Mm-hmm.
like, you do? Like it was a surprise, and it actually ended up becoming a topic of one of the videos we made, which is diagnosis, and actually having that label can be a really hopeful thing because it informs a treatment plan. And depending on what's going on, the end result could look like it not seeming like you quote unquote have anything.
Right, right. I think labels, if they're correct, if they're accurate, if they resonate with someone, can be really helpful. And so some people are like really against psychiatric diagnosis and psychiatric labels. I usually follow the patient's lead, and if a diagnostic construct works for them and helps them to understand their thoughts and behaviors, then we'll use it, and it will also help guide treatment because the wrong diagnosis can lead you down
Mm.
paths for things you really don't need and can be quite harmful.
Tell me a little bit more about that. There's kind of a competing philosophy that you allude to around diagnostic criteria or using diagnostic language. There's obviously not a right or wrong here based on what I'm picking up on what you're saying. Can you talk a little bit about those two sides and how you go about navigating which side? You said you follow the patient's lead. What does that look like?
Yeah, so I think I we have these constructs. Unlike diabetes, diabetes has a blood test, right? You can check and see if somebody has diabetes, yes or no. In psychiatry, we don't really have signatures like that right now. There's hope we will. There's hope certain MRI scanners, certain EEG patterns will give us a little bit more signal of like, yes, this is this entity, just like diabetes. But right now, we're not there. So the best we have are these constructs, right? And they're made by committee. DSM-5 is the book that we use, sort of our psychiatric Bible. Everyone follows it, made by the American Psychiatric Association. And it's basically our best attempt to organize human behavior. And it's imperfect, but it's better than nothing. Because if you have
Mm.
nothing, then how are we going to communicate with each other? How are we going to understand, study things? How are we going to figure out what treatments might work? So we need something, and I think it's the best that we have right now, and it's being revised. They'll start working on DSM-6 soon, and I don't think also the labels shouldn't be pejorative. So this comes up a lot with borderline personality disorder in particular. Used to be this diagnosis, people would say it to say this patient is a difficult patient, they have borderline personality disorder, and the myth was that treatment doesn't work and these patients don't get better. So nobody should use that label. You shouldn't diagnose it, right? That was the old school teaching. The newer school teaching, and more research has come out and more therapies have been developed, is that it is quite treatable. People can get better. And I have found if somebody really meets criteria for borderline personality disorder, that is very organizing for them to understand that other people are feeling these intense feelings that they are and are having the same struggles, and that there's like a path forward. There's like a way out of the chaos. So I don't think of that label as pejorative. But if you're somebody that doesn't know how to treat it, then people don't want to give diagnoses, or it's like, I'm sorry, you have this diagnosis. There's nothing I can do. Oh well, right?
Mm.
But once we start to have effective interventions, I think these diagnoses can be absolutely life-changing in a positive way. And they're not life sentences either. None of these diagnoses mean you're going to have them forever.
Yeah. I want to come back to the DSM and this idea of construct validity, but
Hmm.
first, I would love to know your opinion on the history. We used to think that borderline personality disorder was essentially a life sentence, and now we
Hmm.
know it's actually, assuming it's accurately diagnosed, it's actually a hopeful diagnosis.
Absolutely. Yes.
Yeah.
So we know, the majority of patients after, a decade are not even going to meet criteria anymore. They may have some symptoms, but with the right treatment, there's going to be a higher quality of life, and they're not going to be doing what we call like the life-threatening behaviors, right? We kind of tier one behaviors like suicide attempts, other types of risky behaviors, self-injury. We
Mhm.
have really good treatments for that, like dialectical behavior therapy or DBT, another acronym. Um, we also have treatment that I specialize in, which is mentalization based treatment, comes from the UK, a bit more psychodynamic based, and it can work really nicely hand in hand with DBT. But I think the point is for me, when I see someone coming in, I specialize in more complex cases. So someone might come in with a diagnosis of treatment resistant depression, and they may really have treatment resistant depression, in which case we have treatments for that. TMS works well for that, esketamine works well for that. Um, Even ECT can work well for that. But sometimes those individuals, it turns out, more have a personality disorder and they've never had effective treatment for it. And so I'm able to make that diagnosis and get them on a different path rather than just throwing, the literally like the 25th med at them, right? We're going to say, you know what? I don't actually think there's a pill right now that's going to help you with your struggles. So let's get
Mm.
off that hamster wheel and let's try some therapy, and that can be, really refreshing. There are also people that have both, and we say, you know what, get DMS and get MBT or DBT, and we're going to kind of do a whole kind of overhaul here, but we're going to get things on track. That's the bottom line. Is I think a whole other subject is like euthanasia and physician assisted suicide, and there's this, Switzerland
Mm.
has that, and occasionally we'll have patients um, who want to go there and they want to end their lives, and thinking of psychiatric illness as these terminal diseases. And, once you start to see effective treatments, that's like, but no, that's not true, right? And people with
Mm.
borderline personality, so going to do euthanasia, I mean, politically, whatever, it's a different issue. But as a clinician, I have to say, my medical opinion is that's not a terminal disorder. We have treatments for that if you're open to looking at them.
One of the things I've always admired about you as a fellow clinician is how you're able to stay on top of so much of the research. So when I was in school, I learned that borderline personality disorder was something that you could treat fairly effectively. I've talked about
Wonderful.
that in my content, and I got a few too many comments, in my opinion, of saying, "Really? Since when?" And all this stuff. And for me, it was one of those things that was. It's not like I read a specific study that claimed that. It was multiple studies, multiple conversations I had, different supervisory experiences that led me
Hmm.
to have that clinical opinion. I remember you talking about that there are some people working on treatments for narcissistic personality disorder. Narcissism is a huge buzzword. It's all over social media, all over the
Hmm.
internet right now. And it's often seen and talked about as this thing, oh, they're a narcissist,
Get
canceled,
rid of them. Yeah,
goodbye. Can you say a little bit more about that? Because my suspicion is that we're actually approaching a time where it will be viewed similar to BPD
absolutely.
in terms that
Yeah.
it's treatable.
In terms of the treatment, yeah. So
Yeah.
mentalization based treatment, it started off in the UK for borderline personality disorder, but then was adapted a bit for antisocial personality disorder. So another disorder where many people today, I mean, many of my colleagues will say, "Oh, no, 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 antisocial personality disorder, you can't treat that. Don't work with those patients. That's a lost cause unless they want to go be the CEO somewhere, so multi-billion-dollar company, or in jail, right? That's what happens to them." Um, but actually, MBT can work with them. It doesn't look exactly the same as it would for BPD, but it can be modified. And similarly, there's folks looking to modify it for narcissistic personality disorder. There are other types of treatment called transference-focused psychotherapy, where there's, groups treating narcissistic personality disorder, and that was one of, the things that I would find McLean, where I trained and then worked, was kind of a mecca for personality disorders, and so people would come
Mm,
from all over the world with personality disorders, but BPD was the sort of headline one. It was the one everyone thought of,
mm,
and so I would get a lot of referrals for BPD, and I would sort of say, well, I'm not actually sure all these people have BPD. They have a personality disorder. Like we can all
yeah.
agree something's going on, but some of them were much more narcissistically organized and they didn't respond the same way to DBT. In fact, they thought DBT was,
Mm.
for basic, I could teach the course. This is basic. What is this? I don't need
Classic. Yes.
skills. Like, no, no, no. Right. And they found it like some of the language, the acronyms, they were really not interested in it. So that doesn't work for them. But mentalization based treatment, transference focused therapy that are a bit more psychodynamic. So we're not talking Freud lay down on the couch, but we're talking, the dynamics between people, how my mind works, how your mind works, reflecting, imagining,
Mm,
being curious. That type of treatment with them, particularly in group settings, actually, for both narcissism and antisocial, running groups using like mentalization based treatment, it can be transformative because I don't know how many times, like a person with NPD will say, I've been in psychotherapy for 30 years with only the best, only the best Dr.
mm.
McMillan, and all the
Of course,
fancy Park
they
Avenue
prefer that.
shrinks, right? The analysts, they were going to daily analysis, right? Then they're just really amazing. But they seem to have a very sad life and they're not functional and they have
Yeah.
it's not good because they've just gone to an office and talked for an hour to a person that's not really helping them to be part of society. Put them in a
Right.
group, and when I would run these narcissistic groups, we would have them telling each other, it's just not really that interesting what you're saying. This again.
Yeah.
I don't want to hear this. And and then they would be like saying that to each other, and they would see how they were coming across, and they were able to receive that feedback from each other in a way that me as the individual therapist was never able to give them. And then when I would see
Hmm.
them individually after the group and they would recount, well, can you believe so and so said this or that? And in individual therapy, where you don't see them in a group, you just sort of take their word for it. But if I was also their group
Yeah.
leader, I'd be like, well, that's an interesting view. I was in that group also, and I actually had a wildly
Mm,
different interpretation of what went down. Let's talk about that. And so I found that so exciting. I found that so able to help people in new ways that were totally told, you know what, you're not going to get better and you should be, canceled and just like how to deal with a narcissist in your life. All that stuff is like, okay, you do what you got to do if you have that person in your life, but someone's got to
right.
help them too. They're not going to just disappear.
Yes, correct. I love facilitating group work, and I'm very excited to track this as it continues to get studied and emerges. And I'm just having this thought: how perfectly ironic and funny is it that the narcissistic personality cluster seems like it's getting most helped in a group setting?
Yes, yes, not the, $1,000 an hour fancy
Yeah.
analyst. It's with the group. And you know what I love about these groups too was like, we're in New York and we some private pay, some insurance. We would have people on Medicare, Medicaid in this group
Mm,
with, titans of industry. And they were relating and they were having the same struggles and they were all in group together. And that you want to see that, you want to have that happen rather than people just be sort of in their own little echo chamber of individual therapy.
tell me a little bit about, you talked about the DBT approach versus the mentalization based therapy. What's coming up for me is there's the DSM you were talking about
Hmm.
earlier. These are the constructs that we have. A lot of people, at least in my comment sections, will bring up, well, what about the ICD? And then ones that really know the craft, maybe they're in shrink school or they're not, will also be like, well, what about the psychodynamic diagnostic manual? And so for you, as someone who is so integrative and eclectic in her orientation, how do you think about these different ways of validating these different constructs and understanding them and using them to understand and help the people that you help.
Mm. Yeah, so the ICD is tricky. That is what we use for all our billing, but that's International Classification of Disorders. And the United States is always like at least one iteration behind what the latest one is. So we conform to that for billing purposes, but I don't take too much stock. I'm not reading that. We generally as psychiatrists, and I think really across the world, the psychiatrists, even in other countries, do look to the DSM as the sort of gold standard. It is the American Psychiatric Association, but it is the sort of go-to largest organization. And so those diagnoses are generally that's where in the main body of the DSM, that's where I use my common language. And then for
Mhm.
billing, I use the ICD. As far as the psychodynamic diagnoses, um, the DSM is interesting. It doesn't really get at that. It really just describes symptoms.
Mhm.
It doesn't generally even describe causes unless there's a very specific cause, like Huntington's or something.
Mhm.
Or for PTSD. PTSD, you have to have an inciting event, which is some kind of trauma. But it's pretty much just descriptive, whereas psychodynamic, you're getting much more into the defenses people use and all sort of kind of formulation. So I just think that's like a different process. Like if I'm just going to describe a phenomenon,
Mhm.
like the DSM is going to be good enough. If I want a psychodynamic formulation, that's not going to be like you can have both. They're just sort of
Mhm.
different tools. Does that make sense?
It does. I agree. I was trained psychodynamically, but of course, I'm very familiar with the DSM, whether it's through insurance or just kind of understanding the person that's sitting in front of you. In a way, it's a perfect segue into the topic we really want to get into, because what we're really talking about is this word. You mentioned it earlier, this word crazy. It doesn't really
Hmm.
mean anything, at least not to
Hmm.
somebody that works in this field. I recognize that it's colloquially used and referred to, but if you're in therapy or if you're a therapist, you're asking a much more detailed question. What is actually going on with this person in front of me? What is their dysfunction like? What is the cause? What is the personality structure? We were talking about personality disorders earlier, and in a way, this is just my personal opinion. I do think there's some of the most stigmatized brands, if you will, or types
Absolutely. Mhm.
of mental disorders, and the fact that we're making progress on so many of them. Like you said earlier, diagnoses are hopeful, or they're supposed to be hopeful. Um, let's talk a little bit about the stereotype of that, though. That the reason someone that doesn't know us and is maybe just tuning in and assuming they even listened this
Mhm.
long into the episode would be like, oh, well, Dr. Carlene and Joe got into the field because they're crazy or they have
Mm.
fill in the blank. What do you think about that cultural trope?
Hmm. Yeah, I remember when I was in high school, we went on an exchange to Mexico City, and I was paired with these two kids, and very nice kids. And I quickly learned that the parents were both psychiatrists, and then I learned that like the kids were like using cocaine, like wild, like it was just, and the psychiatric parents were a little weird, like it definitely fit that stereotype of like that kind of eccentric like Wes Anderson film kind of vibe. I don't think that's universally the case. I do think that people gravitate towards the mental health field, like it's an enriched sample of people that either have had a psychiatric illness themselves or they have a close loved one that's had that. Not
Mm.
always. I've definitely met people that are more interested in like the real hardcore science of it all as psychiatrists who like are into neuroimaging and it's like brain is the next frontier. There's sort of one group. And then the other group are people that probably were at some point touched by mental illness in some way. And then there's probably a third group that just sort of didn't know what they were going to do, so they majored in psychology or they picked
Yeah.
that in medical school because they got a good
Mm.
grade. It seemed pretty easy. Like there's different reasons, but I think that there is a large sort of middle segment of people that when you scratch beneath the surface, they will say, why they're in it. And generally it has some sort of personal tie-in or family tie-in or a friend,
Hmm.
right? It could be their roommate or their best friend or
Yeah.
something had a psychiatric illness or something.
Yeah, I think that second classification that you gave is certainly one that I've had in my experience and I see amongst a lot of my colleagues or friends who are also clinicians, which is it's not that they haven't had their own psychiatric struggles, but the real interest in the field got birthed by learning how to have compassion or learning how to sustain a relationship with someone who was really, really struggling. And in a way,
Exactly.
I do feel like that practice I've had. So I've talked about this before, but for those of you who are listening who don't know, I lost my dad at age 11 quite unexpectedly. And that understandably put my family system into a brief period of chaos. And by brief, I mean
Hmm.
years. And it wasn't just my own experience with grief, but it was watching how different people navigate the grief process differently and the different concerns that came out of that. I do often think about how that has probably informed my ability to have incredible patience with my clients or patients who I'm treating, regardless of what the issue is.
Absolutely. Yeah. No, I mean, I think we've all had those experiences. I mean, mental health concerns and tragedy affects all of us in some way. So I think there's some disposition, some people that are more curious about that, are more empathic,
Mhm.
more wanting to talk about feelings, and that combined with some life experiences, gets for a workforce that hopefully is closer to the things they're treating than otherwise.
I wonder if part of it has to do with the pre existing personality structure. I'm thinking of the big five, maybe people that
Mhm.
are a little bit more open, a little bit more agreeable, probably gravitate towards the field than someone who is, I'm thinking, what might the opposite be of our profession, like like a corporate lawyer. Someone who's less
Yeah.
agreeable, really thrives on being disagreeable, isn't super open, likes a lot of structure, you know, there could be something
Yeah.
there.
It does not tend to be who goes into the helping type professions. You're right. Yeah. I don't
Yeah.
know historically it always used to be like that. But at least at this point, people know that they're going to probably do a lot better financially if they go be a corporate lawyer. So you have to really want to do this, I would say,
Yeah.
right? This is the thing. People are not generally going into this because this is in medicine, we have the road to happiness, radiology, ophthalmology, anesthesiology, and dermatology, right?
Oh,
That was true when I
right.
was in med school. It's true now, right? These are the specialties that people go into for all sorts of reasons, but they're known to be lucrative. Psychiatry, primary care, family medicine, pediatrics, they're all at the bottom of every chart in terms of the
Mm,
amount of lucrative. So if you're going into it, it's because you're interested in it, hopefully, and you have some
yeah.
empathy and curiosity.
Yeah, sure. Are you aware of any stats or research, or maybe it's just your own anecdotal experience of what kinds of pathologies show up in different professions? I recently was on a panel and actually got the question, how do you help people if you're dealing with similar issues? And I told them, I said, well, I see a very expensive shrink in the West Village. It is a write-off for me. And it's part of my professional obligation, right? To be a little bit more self-aware, a little bit more finely tuned if I can be than my most self-aware patient. But I also joked, and I remember saying something like, just so we're all aware, there are higher rates of psychopathy and narcissism in the fields like law and business and finance and media. So to your point,
Hmm.
what does this word crazy really mean? And maybe there are a lot of therapists that, have their own issues, but the better question is what I'm taking away from this conversation, what kind of issue are you talking about? And is it one that you actually want to deal with?
Yeah, no, I mean, I think it tends to be more like depression, anxiety clusters, kind of going into this. PTSD, right? People who've had their own trauma
Mm,
experience. That's a big reason,
yeah.
particularly
You
for
mean people who
therapy.
gravitate towards clinical work?
Yeah, yeah,
Yeah.
therapists and things. Many of them
Mm,
also may have had traumatic experiences in their life and have PTSD. You don't typically see, people with primary thought disorders like schizophrenia. I don't want to overly generalize, but that's generally not, it's
mm,
pretty rare in the population anyways, but those are not generally the people that are going into the helping professions. There is ADHD I think in emergency medicine is a thing, right? People like
Mm,
gravitate towards that, and sometimes intensive care. So I think within like my field with psychiatry, we have emergency psychiatry, and so some of those people tend to be a little bit more cowboy, a little bit more ADHD. Same with like inpatient consult, like people working in hospital systems, they're kind of a different breed often than the people that are working in like the outpatient setting and what might you think of as like a stereotypical
hmm.
shrink, right? The the
Yeah.
the hospital, going in the emergency room, going to the ICU, those I found, at least, I mean, I trained at Mass General. They're very, very well known for consultation liaison psychiatry. And I will say this, there were a lot of big personalities, a lot of macho energy. It was like
Mm,
it was more like surgeons, right? When you think of stereotypes of the
right.
male surgeon, that that's out there, but it's not so much in the like one-on-one therapy outpatient space.
Yeah.
Not the right personality for that. You get bored. If you have ADHD, you're just like sitting with a person all day. That's not probably going to be,
Yeah.
if you, it's like severe. But I don't know. You do
Well,
this. You do
as
other things that
someone,
you'd make your day busy.
yeah, well, as someone with ADHD, it is interesting to reflect on my clinical competencies that were partially given to me. I partially chose. I love groups, I love couples, and I
Hmm.
love what I term the adult children of dysfunctional family dynamics,
There you go.
which, and so
Yes.
that ability to hyper focus, even if it is
Hmm.
technically dysregulated attention, it really does serve me in a lot of ways
Yeah.
working with those three different categories of
A group,
patients.
yeah, perfect. Yeah, my
Yeah.
husband is also a psychiatrist. He has ADHD. He's written a lot about it. Very different personality from me. But I think, likes, yeah, likes groups, likes family work. I also do like family work. I don't personally have ADHD. Much to his frustration sometimes. There's just different brains. It's not that one brain is better. They're just different, right?
Yeah.
But I tend to be more interested in like complexity and sorting out kind of the signal from noise in a way that's different
Mm,
than like the sort of wanting a lot of different stimuli and wanting a lot of change, in which is more of
yeah.
the way he gravitates.
Yeah. Dr. Carlene, you're talking about the types of patients that you like to work with and how that corresponds to your personality and who you are as a person. Someone might be listening to this and they might be, I would argue, cynically thinking, well, that type of crazy just matches her crazy. What would you say about that?
No, I mean, I'm very, I would say I'm very calm under pressure and fairly high in agreeableness and diplomacy and whatnot. So sort of in a lot of ways quite different from say like borderline personality disorder. I don't know. My
Mm.
husband thinks I'm a little narcissistic. It's Harvard and all that, so I guess it just has
Yeah.
to be. But that's probably fair. So I don't have that type of chaotic energy with patients, but I tend to like patients that are bringing that into the room, and are needing a lot of help to kind of like regulate and see me as like a constant presence. Sort of like, my husband always says like, these videos were like I guess like recently, like, Alaska Airlines, the door fell off the plane and the pilot just sort
Mhm.
of calmly landed the plane. Like that's just sort of how I am. It's like the plane's missing a wing, but I'm still going to land it. That's my temperament. So for me, that
Mm.
that that works with a certain type of patient that other people sometimes find overwhelming, and don't want to work with. Um,
Mm.
that's sort of who I am. I don't know. My mom was a high school English teacher and always liked to work with some of the more challenging students. And so I think you said earlier something about like as therapists, we're looking for like what's the dysfunction, but I actually, yes, I look for the dysfunction, but I actually look for the function. Like I really try to hone in on like what are the
Mm.
areas of strength for this person? What have they got going for them?
Right.
Maybe all they have going for them is that they showed up for the appointment today, and that's a small thing, but like we can work from there. So I come at it like from that, I think, and that's probably more to do with just like my upbringing and how my mom was, and my dad was a teacher as well. Like just seeing the sort of hopeful potential that others maybe have overlooked.
Mm.
So. That,
Well,
yeah.
instilling hope is such an important, what we would call a protective factor.
Hmm.
And you mentioned earlier that you often see people that are quote unquote treatment resistant.
Hmm.
You are often not the first stop on their mental
No.
health journey.
Yes, yes. So I'm pretty selective these days about the patients that I take. And, there is a lot of what we call cherry picking that happens in the field where, like even in a city like New York, where there's a lot of mental health professionals, many um, skew towards wanting like lower acuity, a bit more higher functioning, working professionals. Um, those type of patients, if they, come knock on my door to see me, I actually refer them to colleagues. The ones that I see tend to be, tried everything, it's not working, long list of diagnoses, suicidal thinking, kind of a lot going on, but wanting to get better. And so I like those cases. I like to figure out what is the right diagnosis or diagnoses and what is the right treatment and can we work together to find a treatment plan. And so I like more, like a lower quantity of patients, but more higher in intensity. That's what
Mm.
I kind of cherry pick for, which is the opposite. And it's just, I think I learned working with patients like that at McLean, really, state of the art psychiatric place. But I also learned at McLean that the repeated inpatient hospitalizations, just program after program, ER after ER, was not serving them well. And so I had some really good mentors, really good supervisors to teach me there's ways to work with those folks in the outpatient setting to help them really only use those levels of care as, really a last resort if you have a very specific reason that you need to be there, but not as just like the knee-jerk response to a concern about suicide.
Mm. You're someone who's had such a lovely breadth of experience, everything from what sounds like the higher functioning clients in New York City who wanted to see, the best of the best
The
psychiatrist, to
narcissists, yeah.
people. Yes, exactly. And the people who, it was in some ways, it was, one of their last stops on their mental health journey. They were very, very desperate. They were unmedicated, whatever it might be. Given all that experience, how do you utilize diagnostic and psychological jargon when you're both patient facing, but also uh, public facing,
Hmm.
whether it's with loved ones or speaking on a public platform? One of the things I talk about in my content all the time is we can't medicalize everyday life. You referred to yourself earlier as narcissistic. One of my most viral videos actually uses surgeon as an example, and I'm dressed in scrubs and a stethoscope.
Oh,
And I
nice.
say, it's actually good for me to be a little narcissistic if I'm going to be cutting you open. It's actually
Right.
adaptive in this
It's totally.
circumstance. Yeah.
Totally, totally. You have to,
Yeah.
yeah, sort of narcissists and bipolar, like we wouldn't have a whole lot built in the world if it weren't for people that had somewhat grandiose ideas some of the time.
Mm-hmm.
So you have to kind of know when everyone, there's a healthy amount of narcissism. It's unhealthy when you can't maintain relationships, which, I'm thankfully able to do. But
Mm. Yeah.
yeah, everyone has like a range on these traits, right? That's the thing when you say everybody's crazy. It's like, well, everybody, there's aspects of borderline personalities, or who of us hasn't had, someone break up with us and us get upset and want to have them back and maybe call them one too many times, right? That's pretty
Mm-hmm.
normal behavior. It can become pathologic when that's like overwhelming your existence all the time, but we can all sort of relate to that general feeling of not wanting to be abandoned, right? And same with narcissism. Like we all need to sort of, well, we all have insecurities, right? Narcissism is oftentimes just a defense against feeling like you're an imposter or you're not worth it, and so you kind of project something else. I haven't met anyone that isn't doesn't feel that way sometimes about some circumstance and has to
Yeah.
sort of put on a confident face, right? And we call it narcissistic supplies, I think is the psychoanalytic term, right? We have
Mm.
to we have to use those to move forward with our day. Otherwise, you'll just stay at home and not do anything and just crawl into a hole.
Talk to me a little bit about how you take care of your mental health. So those different, because one of the things that we're implicitly discussing is we all have these traits, and the traits can become more intense, more severe.
Hmm.
They can render us a little bit more dysfunctional, depending on a variety of factors, both internal and external. How do you think about self-care, if that is the word you use for it, for
Absolutely.
yourself, given that you're in a helping profession?
Yeah, yeah. So most mental health clinicians, psychiatrists included, were encouraged to, see a psychiatrist, see a therapist throughout our training. I'm fortunate that I've been seeing the same psychiatrist. I had a little break when I was pregnant and I saw a specialist, but for, a decade or so, I've seen the same person. He was in Boston when I was in Boston. And then I moved here, saw a perinatal psychiatrist when I got pregnant, and then lo and behold, he moved to New York too. So now I see him again, and this is before everyone was
Mm.
doing telehealth. So he's known me longitudinally for a really long time. I see him every week. I do see a psychiatrist. I do take Wellbutrin. I've taken it for many years. Wellbutrin's an antidepressant. Elon
Mm.
Musk does not like Wellbutrin. He says all sorts of terrible things about it on social media, which I take personally. But I think I'm someone like I haven't had, the severe mental illness that some of my patients have, but I definitely am upfront about saying, what, I think it's really important that I make time to see my psychiatrist, and
Mhm.
I would recommend that to anybody. And I think when I've seen colleagues really struggle is when they cancel the sessions, they say they don't have time for it, or they don't have money for it, or whatever. We're all
Mm.
busy. Like, you really have to make time for it, particularly in our line of work, because it's really hard. We
Mhm.
process a lot of intense stuff, and we can't really talk about it, right? There's HIPAA laws, there's privacy
Yeah.
laws, and so it's nice to just have that space to be able to you know to focus a bit on me. See, now I sound like a narcissist, but no, I think it's it's just helpful to have that person too that's seen you longitudinally over time, and
Totally.
remembers back in the day when you had a job you didn't like that you needed to leave, and maybe and like, just that's great. That's why I get so annoyed with some of these new therapy platforms, the ads, you hear them on NPR and stuff, that it's as simple.
Mm.
You just go on the app and you can request a new therapist if you don't like your current therapist. Well, that's not the work. The work is, obviously you should find someone you like working with. But the idea that, like, okay, therapy's gotten hard, let me just push a button and get a new therapist. That's not what we want to promote. We want to working on
Right.
relationship. And I think that's being a little lost in some of this direct to consumer, almost like it's a fast food, but it's like fast therapy. I don't,
Mm.
not
Yeah,
into
it's
that.
it's interesting. What you're touching on is this idea of, at least implicitly, this idea of rupture and repair within the
Hmm.
therapeutic alliance, and how it is not so much the absence of conflict that allows you to feel close to your therapist, but if you can work through that, like in any relationship, the closer you're going to feel. And as you know, the closer one feels to their therapist, that's one of the bigger predictors of therapeutic success.
Absolutely. Yeah. And I mean, I think if I think of my own therapy, it's very nice to be validated. It's very nice to have someone say, oh, this does sound awful. This really sounds terrible. But the moments that I remember in the therapy are the ones that I was challenged slightly, where I was, advised to have an alternative perspective, or, this person observes something in me or in my past behavior and calls me out on it. That's where the work gets done, right? But that's hard. That can be
Yeah.
hard. And
Yeah.
a lot of people don't want to stick with that. They just want the validate me, just say I'm
Hmm.
the best, right? And that's
Yeah.
not really going to be super productive. That's not going to cause sort of
Hmm.
transformative change. You need to have some degree of conflict in a therapeutic relationship, a healthy conflict, where you believe the
Hmm.
therapist does have your best interest in mind and is not just trying to mess with you, but is productively trying to give that feedback. That's what you need. And I worry that that's lost on the apps where you can just change therapist. I worry that's lost with chatbots that you can text at 3 a.m. and they'll respond
Hmm.
straight away. No, a therapist would say, it's 3 a.m. I'm tired. I'm not able to really help you as best as I can right now. We need to get it to the point where you're not calling people at 3 a.m. in crisis, because you know what, that's going to wear
Mm-hmm.
people out, right? That's the work. That's, we always say, grist for the mill. That's what we want to do.
Right.
And that, I don't want that to
Right.
become a lost art in this sort of fast therapy world that we seem to be moving towards.
Yeah, I'm not sure to what extent it's a therapy culture problem or a tech problem or a TikTok, Instagram
Mm-hmm.
problem. I know that for me, I was trained to be incredibly person centered and validating and nurturing. But as soon as I went into my first internship or my first practicum, it's not that I wasn't those things, but I got so much permission to push back and to. It may sound like it's malicious or manipulative, and it's not, but to play with those boundaries
Mm-hmm.
with the patient. And that's where I think the art of therapy comes into it, because I had to learn what's my style. I use a lot of humor. I do a lot of what's called empathic confrontation. That's often where I start to play with whatever that line is and see, well, you say you want direct feedback. How much direct feedback do you actually want? And what does this actually look like? And it completely depends on the patient as well. I brand myself in my private practice. I'm a direct therapist. Therapy is not
I like
for
it.
a good
Mm-hmm.
time. Therapy is for a good time, not a long time, is what I
Mm-hmm.
say. And people will reach out to me because they're actually hungering for that more directive approach. But I also know I have friends and loved ones in my life who are all, that's great. I love that marketing strategy works for you. I would never reach out to a therapist like that. I am way too terrified to talk about whatever it is that's going on. And great, there's therapists that can cater to that style as well. Yeah.
Exactly. Unless the
Yeah.
person is a narcissist, in which case they really should have
Oh.
someone who gently is able to push them a little. And I think it's important what you said about boundaries, because there's a difference, I think Glenn Gabbard talks about this, a difference between a boundary violation and a boundary crossing,
Mm,
or crossing the frame. And a boundary violation is really, that's not appropriate, right? That's sleeping with a patient, you're harming patients
mm,
in very clear ways that are to satisfy your own sort of needs. Those are not good. Boundary crossings can be therapeutic, right? And in child psychiatry, you see more of this, right? A child gives you a gift, a little thing they've drawn, and child psychiatrists like, thank you for the gift. It's very nice, right? Sometimes adult psychiatrists make this whole thing, oh my goodness, this is a boundary violations. They've gotten some gift of some kind. Well, it's a, it's a mug. It's not Louis Vuitton luggage, right? John Gunderson once told me you got like a set of Louis Vuitton luggage from a patient that he had to return, right? And that was a bit much. But a little mug filled with cocoa for the holidays is fine. That's a nice human gesture. We're two humans. We care about
mm.
each other, right? That when you shouldn't forget that you are a human being and this is a real relationship. And you hear this too. Patients will say like, "Well, you're not. This is not a real relationship. You're just paid to be here. You're like a paid friend or paid whatever." But that, while we are compensated for our time and the work that we're doing, it doesn't mean it's not a real relationship. It doesn't mean any more than it's not a real relationship that you have with your coworkers or other types of professionals, right? I mean, people go to their hairdresser and they can feel connected and have the same hairdresser for a decade. You have a real
Right.
relationship even though I'm paying that hairdresser. That it's the same
Yeah.
thing, and we sometimes lose sight of that, I think.
Yeah. I would also say I was certainly surprised to not just learn, but also experience that even though the intimacy of the therapeutic alliance may be manufactured, as you put it, it sometimes, frankly, feels more intimate than some of my intimate relationships, because you have that permission in that confidentiality, in that professional bubble, if you will, to explore certain thoughts, ideas, fantasies, and rabbit holes that you just wouldn't with your partner, because it could be relationship ending for you to do that.
Absolutely. Absolutely. Yeah. No, I mean, I think it's a really privileged space. It's really, I mean, privileged in the legal sense, but also just it's like a privilege to be in the room with patients when they're and bearing witness to some of the things that they're sharing. And you're not part of their larger family system. I mean, sometimes they're small towns and stuff, but for the most part, you are a bit more of a neutral third party, and that can be just so valuable. Like we get so close to our own problems. That's why like shrinks need to go see shrinks, right? We can't. we can't do this for ourselves because we're too close to it. We need
Hmm.
somebody who doesn't have a horse in the race to weigh in on things and be like,
Yeah.
look, from my outside perspective, this looks like this, and this feels like this, and this is different than when you're in
Hmm.
the middle of it. And that's true universally. It's true for everybody.
Yeah. It's so hard to know yourself.
Yeah,
It takes
without
practice.
we know ourselves through reflections in others and how others
Hmm.
interact with us, right? We're a very social species, so you can't just sort of know yourself in isolation. You need to know yourself in relation and reflect, and that's part of what the therapy space can give to you in a way that friendships really can't. And it is tricky for me sometimes with friends where I do feel sometimes they kind of are trying to cross over into that therapy role with me, and
Mm.
I don't want to go there. Very different,
Yeah.
different headspace to be in.
Yeah. That was one of my big surprises. The similar to the you got into this because you're actually crazy or you're trying to figure out your type of crazy. There is this phenomenon, if you will, the longer I practice, I've started to experience where people will, on one hand, almost kind of accuse you of wanting to fix people or being in therapy mode all the time. And not that I can't slip into that accidentally. And if I do, people can call me out on it and it's fine. But more often than not, what I experience is people are kind of trying to coax me into giving the advice or to being empathetic.
Yes,
And I'm like, we're at drinks right now. I'm like, wait, what happened? you know?
exactly. Right.
Yeah.
You're doing this all day. You want to be off the clock. Yeah. Or I don't know if
Yeah.
you've had like, I like a good TV shrink, but shows just about therapy, I don't want to watch. It's
Oh,
not fun. It's
totally.
work. It's work.
Yeah.
It's if it's like Billions with like Wendy Rhodes, it's very fantastical, right?
Yeah.
I can watch that, but I'm not going to watch. What was that show where it was just in treatment?
Mm, yeah.
I don't want to watch that at night. I might want to watch that as part of a training or discussion with peers, but it's
Yeah.
not fun to watch that. And even like reality TV, I struggle with these days. I
Mm,
don't find it fun. I mean, once you know about personality disorders and everything, I've talked to directors on for reality producers. Reality TV producers actively select for personalities that are big, that are going to clash, that we would
mm,
consider a personality disorder in some way. And I think when you think about, like you asked me about self-care, part of that is like, who am I going to surround myself with, right?
mm.
If you put anybody in with a bunch of people like that to live together and all of that, you're going to
Yeah.
get reality TV type drama. And I don't want to watch that if I can't sort of help in some way, just like it's like painful
Yeah.
to watch. We're like, no, you need to mentalize. You're not mentalizing. I want to get into my work mode when I'm watching the
Yeah.
reality TV.
Yeah, absolutely. We are hoping to do a reality TV and mental health episode on Therapy versus the World at some point this season. I don't know if you've heard, but I believe it's the first season cast of Love is Blind is unionizing or attempting to
Oh my
unionize or
goodness.
suing for certain rights. I'm not totally clear on the details, but basically they're saying, look, there are limits to the ways you can treat us and manipulate us for spectacle. And fair
Yeah.
enough. And I'm interested to learn more.
Yeah. Well, it's like when you think of like therapists like use their term boundary violation, right? Reality TV shows are basically just producers, just like like boundary violations at scale. Let's turn the camera on, right? As long as nobody like dies, we're gonna watch what happens. And
Mm,
they're just the producers are in it to make money and get ratings, right? Which is very, very different from a therapist working with someone with a personality like that, who's really trying to help them to not have those types of explosions that make for good TV.
I'm right there with you. There was a season, and maybe it sounds very typical, but there was a season in grad school where I got really into reality TV because I was just had all this new language and knowledge and tools to analyze. And then after a
Mm.
while, I was just like, I can't even because either like you, this is too painful to watch, or I'm pretty sure you're acting, and I just like
Yeah,
have something
there's
better to
that.
do with my time.
Right, there is. That's true. There's can be an inauthentic, like there's a staging where it's like that's not really a person having a meltdown, and then when it is, you can kind of feel that. I do like some true crime and things like that, like the
Mm,
Robert Durst story and stuff. that's sort of interesting to me. But that's like
Yeah.
it's like really happened, and it was not producers manufacturing it.
Yeah. What you said earlier about watching therapists being portrayed on TV. I love the show Billions, and actually, no, she convinced me to go to grad school. She was a real life Wendy Rhodes, not who the character was based off of, but a performance coach,
Uh-huh.
on Wall Street. And so I enjoyed that just because of my personal connection to it. But I tried to watch, what is it called? Couples therapy. And I had
Oh
so many
God.
friends who were so into it. And just like you, I was like, number one, this is my work. This is not that interesting. Number two, if it were to be interesting, I need to see the whole session because I don't know how she got there in these different clips. And
Exactly.
it's just not, I know too much.
Exactly. We know, yeah, we know too much. Yeah. That's funny. Yeah.
Yeah. Well, we're going to wrap up in a few minutes here. Is there anything you want to leave the listeners with? Anything that you want to say? Any words about any of the endless topics we talked about today, from narcissism, borderline personality disorder, treatment resistant conditions, how the word crazy is meaningless and not necessarily very helpful? Uh, Anything you want to say at
Yeah,
all?
we're all crazy in our own way. I mean, I would say, just to kind of circle back to what we talked about at the beginning regarding borderline personality disorder and it being a treatable, hopeful condition, for any listeners that are interested in learning more about how to help someone with that condition. There's Good Psychiatric Management of Borderline Personality Disorder. It's a quick little book written by John Gunderson and Dr. Lois Choi Kane from McLean. And it's just like a really basic, even somebody with BPD, I think, could benefit from reading about it, and family members. Really, really basic, common sense approach to working with those folks. And it also goes over a lot of the hopeful statistics of recovery. So
Yeah.
I highly recommend checking that out.
All right. Well, I personally always appreciate a good book recommendation.
Mhm.
I want to thank you so much for coming. There's so many other topics and rabbit holes that we can go down. So we'll
Absolutely.
definitely have to have you back at some point. For those listening, please like or subscribe to Therapy versus the World on YouTube or Spotify. It's the easiest way to support us. And remember, Therapy versus the World episodes are available early and ad free when you subscribe to Luminary.